Welcome to part 3 of Changes Now, in which we focus our attention on practice models, the many different practice models that are out there, some quite small, some novel, some quite well established, as we consider the evolution of pediatric dentistry and the direction it may take, and then the role that we play as advocates for ourselves, for our profession, for our specialty, and for our patients and their families. The next 3 slides describe 12 different practice models, starting with the common ones and then going to the ones that are more novel or just smaller. The first practice model, the one that is well established and has the longest history in modern dentistry in the US, is the solo practice model, in which a single practitioner with staff, typically with one office, have an office that is managed by the dentist or the staff or contracted business services. As solo practices hire additional dentists and become small groups, things change a little bit. The players are multiple dentists and their staff, typically 1 to 3 offices, managed still by the dentist or staff in contracted business services. As they continue to grow into larger and larger groups, where you may have scores or 100 of dentists, the numbers of offices increase, tens of dentists, tens of offices to hundreds of offices. And at this point, these large groups engage professional managers, professional business managers, and sometimes those professional business managers are themselves dentists, they're dental entrepreneurs, or they may begin to affiliate with dental service organizations or dental management organizations, which brings us to the fourth model, which is a large group administered by or a number of small groups or even solo practices that are aggregated under the administrative and organizational management systems of DMOs or DSOs. These have been regarded as corporate dentistry. These are organizations that provide administrative, accounting, IT, purchasing, advertising, HR, financing, and other business services. DSOs may manage independent practices where the practice maintains its own identity, or may bundle those practices into an identified group. Many of these DSOs and DMOs now have significant venture capital affiliates. While the prior slide covered most dentists in most practice situations, there are a number of other that you may or may not be familiar with. The small group networks are medium-sized aggregated practices. They're like DMOs or DSOs on a small scale. They're typically 25 or fewer practices or locations, and they tend to be managed by dentist entrepreneurs. On the safety net side, we have federally qualified health centers. These are health centers, community health centers, that meet specific requirements of the federal government. If they are approved by the Health Resources and Services Administration, they're called FQHCs, or federally qualified health centers. If they are instead overseen and managed by the Centers for Medicare and Medicaid Services, then they are called lookalikes, but they're virtually the same. These are community-based organizations. They provide primary care services, both medical and dental. They must include preventive dental services, and they may include expanded restorative dental services, which many do. A third model is the mobile or portable model. These can take a variety of approaches to bringing care to patients and populations. They may be for-profit, they may be nonprofit, they may serve specific sites like workplaces or schools, community centers, adult daycare centers. They may provide a van that has the dental equipment all set up, or they may deliver portable dental equipment to a site. A fourth of these lesser practice models is voluntary, and there are a whole bunch of these. These are where dentists bring their services, usually in community sites, sometimes in private offices, and provide care to people who have the greatest difficulty accessing care. And they go by a variety of names. There's Mission of Mercy, remote access medical, donated dental services, and quite a number more. As we move into the last four models, these are relatively small or novel. Let's start with the first, the virtual dental home. This was developed by Paul Glassman in California on a hub and spoke model in which the hub is the highest level of dental provider. The spokes are from that dental provider out into the community, into homes and community sites where dental hygienists meet directly with patients in their home and community sites, collect diagnostic information, identify the patient's needs, transmit that information back to the dentist at the hub in order to determine whether care can be provided by the hygienist in that home or community site, or whether the patient needs treatment at a local dental facility, or if their care is more sophisticated or demanding and requires that the patient transport to the hub to receive a higher level of dental care. So that's a virtual dental home. Teledentistry became expansive upon the COVID-19 pandemic. Before that, there was relatively little use of telehealth in dentistry, but those models have expanded to face-to-face virtual consultations, store and forward consultations where the information is collected and stored and then taken forward to the provider or to a specialist or to an independent hygiene practice later on, or remote patient monitoring. So these are various ways of using telehealth technology to advance oral health and dental care. Then we already talked about how practices may aggregate from solo to small group to large group to DMO organized, but then there's another level on top of that, which are accountable care organizations. These are large, comprehensive, vertically integrated healthcare systems, and they may or may not incorporate dental care. When they do, they may keep it kind of siloed in a more traditional model, or they may integrate it directly into their overall delivery system, which is designed to control cost, monitor quality, and enhance patient experience. Lastly are these workplace dental practice models. Some large corporations provide on-site dental services for employees as an employee benefit. It provides a number of conveniences. The appointment is right there on site. They may do this with a fixed clinic in the employer's site. They may do it as a mobile delivery system, or that may be a pop-up. And there are a couple of corporate examples that you might want to take a look at their websites. One is called On-Site Dental, and another is called Jet Dental. Oh my goodness, I forgot that there are 3 more models for us to consider as we think about where dentists interact with patients or populations in order to provide care that only we have the skills to provide. So one is school-based health centers. These are very much like federally qualified health centers. They're publicly funded, and dental services are provided in schools, usually addressing underserved children. Approximately 1/3 of those school-based health centers before the pandemic included dental services. There has been a marked decline in the inclusion of dental services, but we anticipate that over time those will be rebuilt and put back into place. Then there are institutional practices, and they can be in a variety of settings. These typically engage dentists on a salaried basis, and those dentists may work in prisons. They may work for the Department of Defense in military sites or in the Veterans Administration, in the Indian Health Service. There are also some special needs programs and hospitals that hire dentists directly to provide services to specific populations. And then, of course, the one that all of us as dentists came through which is the educational delivery system. That includes dental schools, over 60 of those, residency programs, dental hygiene programs. So there are currently 69 dental schools, 330 US dental hygiene programs, and quite an array of residencies. Taken all together, we're now up to 15 different delivery models. But we want to take a closer look at the common ones to see the attributes thereof. Let's look closer first at solo private practice. This is the model that has attracted many people to the profession over decades. The pros of the solo model are things that people really appreciate and often seek for their careers: independence, autonomy, authority, and they can also be sustainable in small service areas where the population is small. Now, on the flip side, the cons of solo practice are that you cannot generate economies of scale. You can't do large purchases. You can't manage systems in ways that economize. And there's no sharing of responsibilities. So this independent, autonomous person not only has the authority, but has the responsibility of managing all of the administrative and organizational components of practice, which can become quite complex as regulatory demands increase over time. Small groups, the pros are that the owner still manages and has some shared responsibility. There are people to help the owner out, and there are some economies of scale. And within a group, a small group, dentists can sort of specialize. If there's a group of pediatric dentists and somebody has a predilection for treating younger children or children with special needs or children who are teens, whatever, they can pick their favorite component of pediatric dental practice within a small group. On the downside, there's limits to the economy of scale, and there's still considerable management responsibility by the owners and partners. As we move to large groups, the pros are that dentists can focus on care while professional managers focus on administration and organization. There's a lower overhead, and there's assistance with regulatory compliance. On the flip side, you lose independence, autonomy, authority, and the dentist may still maintain some management responsibilities. Now, when you have a large group that is professionally managed by a DMO or a DSO, then you have some additional advantages: greater access to capital, more professional managers, and perhaps better position to affiliate with larger health systems, or perhaps to engage with those non-traditional health support workers who can help patients. For example, dietitians, social workers, health educators, community health workers, where a solo or small group or even a large group may not be able to afford to have those people on staff. A DMO or a DSO could and provide those people to address non-clinical health determinants through services that are not normally available in a private dental practice. The American Dental Association's Health Policy Institute does a terrific job monitoring trends within the dental profession, and here are their findings. First off, they find that solo practice is becoming ever less common because dentists are gravitating toward group practices. In terms of ownership, practice ownership has also been in decline, with the sharpest decline amongst younger dentists, those under 35. And group practices are continuing to increase. 20% of dental practices were groups by 2018, and a subset of those groups are affiliated with DSOs or DMOs, the fastest growing practice model. So take some time to take a close look at this infographic from the American Dental Association Health Policy. The Health Policy Institute is also monitoring this shift toward DMOs and DSOs and noting that younger dentists are moving this shift faster than older dentists. So why might younger dentists be looking to practice under the DMO or DSO group practice model? One factor may be higher debt that they seek to ameliorate through perhaps better salaries, but also some negotiation possible with the DMO or DSO with regard to that debt. Lifestyle aspirations, where young dentists may not wish to take on the full range of administrative and organizational responsibilities. Generational mores, where this generation of dentists may feel differently about the need to own and a rejection of ownership responsibilities. It could be that the increasing complexity of practice management is having younger dentists think more about having professional managers. And it may be that younger dentists have less interest in equity positions. But whatever it is, there's definitely an accelerating movement towards DMOs and DSOs amongst younger dentists. So again, take a good look at this informational chart from the American Dental Association Health Policy Institute. Before finishing up with some crystal ball gazing and some attempt to anticipate the direction of practice models in the future, let's step back and take a look at what is known as the dental safety net. The safety net refers to the whole host of structures and practice models that support populations who have considerable barriers to care, usually financial barriers to care. So any and all delivery models that specifically address the needs of people with limited financial means or have insurance support through public insurance constitutes the safety net. And these are quite a variety of the practice types that we've looked at already. Private practices that serve underserved populations are part of the safety net. Federally qualified health centers, school-based health centers, other community-based clinics, some Medicaid-focused DMOs and DSOs, certainly dental education programs, dental schools, dental hygiene programs, hospital ERs and hospital-based residency programs, and institutions designed specifically for underserved populations. So the dental safety net is not one monolithic element of practice models, but can be any place in any of those 15 systems where people who face the greatest barriers to care are able to access care, particularly access affordable care. Let's now finish up practice models with a little bit of crystal ball gazing and see if we can anticipate, as the American Dental Association Health Policy Institute suggested, what the future may hold. Well, as the ADA has suggested, a continued decline in solo practice and in small group practice, with an increase in large group practice and an ever greater market share of DMO and DSO affiliated practice. More workplace-based dental programs as employees demand and request and seek to have the convenience of dental care on site, and increasing funding by venture capital firms. Greater inclusion of dentistry in these vertically integrated, holistic, accountable care organizations, and the continuance of the safety net, albeit marginal, relative to mainstream dentistry. So these are the directions that dental practice is moving, in general, moving toward aggregation, and with aggregation, more and more capacity to deal with changes in how we're paid, that is value-based payment with alternative, value-based care with alternative payment mechanisms, as well as a shift toward population responsibility, not just responsibility for each individual patient, but for the group of patients, utilizers and non-utilizers, who make up the population that you treat.